had on the echo, she had severe aortic stenosis with gradient of 74 by 55. Sir.
Okay. And aortic annulus?
Annulus was 19, sir.
Ascending aorta?
Ascending aorta was 31, sir.
LV dimensions and EF?
EF was 55, sir. LV dimensions, I'm not able to remember, sir. The echo is not with me.
Okay, fine. So you all decided to do a mechanical valve for her, right?
Yes, sir. Yes, sir.
What is the approach?
Sir, approaches for this patient could be midline sternotomy for aortic valve replacement, hemisternotomy, or a right anterior thoracotomy. Sir. 3 approaches for the aortic valve replacement in this patient.
Okay, how do you choose which one?
Sir, at my expertise level, I would only go for a midline sternotomy approach for the patient. But given our age and the comorbidities, and known that it is only isolated aortic valve replacement, we can also choose minimally invasive approaches like right hemisternotomy approach or the right anterior thoracotomy approach.
It's called partial sternotomy. Hemisternotomy would be like a hemi clamshell. That's a totally different decision.
Yes, sir.
It's a partial sternotomy, upper partial sternotomy, or a lower partial sternotomy.
Okay, sir.
Don't call it hemisternotomy.
Yes, sir.
And how do you choose something for a minimal invasive approach? What are the criteria to choose a patient for minimal invasive approach? What are the, if you look at the CT and chest X-ray and CT, what are all the things that you will see before you say, okay, this patient is suitable for minimal invasive, or this patient is suitable for a full-blown sternotomy? Do you know?
No, sir.
That is something that you should know.
Yes, sir.
In the present day and time, when minimal invasive is becoming very popular, you must know which patients to choose. Okay?
Yes. Yes, sir.
Yeah, that is the homework for you.
Yes, sir.
All the exam going fellows. All right?
Okay, sir.
Okay. Because that is important to know the choice of approach. Okay, tell us about the steps of AVR.
Yes, sir. Yes, sir. This patient's surgery, it usually begins with prior to induction, because since it is an AVR patient, the aortic stenosis, any mismanagement during induction can cause a lot of havoc. Tachycardia, essentially low cardiac output due to reduced diastolic filling. Thereby, it can lead to hypotension. We should not let the systemic vascular resistance fall. This leads to peripheral vasodilation and thereafter hypotension again. The steps
in which aortic condition is tachycardia more useful rather than not detrimental?
In regurgitation situations, it is better, sir.
Yeah, so that you have less time for regurg, right?
Yes, sir. Yes,
so
sir.
that is something you must know, and that
Yes,
is something the anesthetist has to be aware of.
Yes, sir.
Otherwise, you may have to tell them that. Okay.
Yes, sir. After the patient is painted and draped, I will do a midline sternotomy, thymus dissection, innominate vein is identified, pericardiotomy is done, heart is exposed with stay sutures on the pericardium. Intraoperatively, my findings would be slightly dilated aorta, and yes, sir, that would be one finding. And I would go ahead with aortic and right atrial cannulation, concentric purse strings on the aorta, and then heparinization until the ACT reaches 480 at
Where
4.
is your purse string?
Sir, it is more closer to the ascending aorta, sir.
These are things that you should be able to tell us, because before you do a purse string, you should palpate the aorta, make sure that
Yes.
you have no calcified area. All
Yes,
right.
sir.
And then if necessary, you may even use an ultrasound probe on table or even a TEE. These
Yes,
are,
sir.
don't miss these steps. Write down
Okay.
all these steps. So when you tell these things to the examiner, he will be impressed and they'll say, okay, this boy knows everything and he's been seeing the things properly.
Yes, sir.
All right.
Yes.
Basically, they are examining you to make sure that you are a safe surgeon.
Yes, sir.
So that is one thing, a site of cannulation. And then what approach, in the sense, what is your iototomy in this patient? Is it
Sir,
transverse? Is it oblique? Is it a J shaped? And when
sir,
do you choose each of them?
in this patient, I would do a J-shaped, routine J-shaped aortotomy, sir, 1.5 centimeter or a finger above the level of the right coronary orifice.
Before that, what is the type of venous cannulation?
Yes, sir. Two-stage venous cannula into the right atrium. First strings taken on the right atrial appendage, sir.
Use the AQ cable. The AQ cable.
Yes, sir.
AQ cable cannula. Okay.
What are the problems with that cannula?
Sir, if it is not too much inside, the venous drainage is not there, and if it is so too much inside, then it may block the hepatic veins, sir.
Correct. And then your venous return will be less.
Yes,
So
sir.
it's very common, because the standard two-stage cannulas that are available commercially are made for Western patients. Our patients are short and the heart is also small. So it can go down and occlude the hepatic drain.
Yes, sir.
So you must be aware of that. And when the perfusionist keeps complaining that his venous return is less, then you have to probably reposition the cannula properly.
Yes, sir.
Yeah.
Then root cardiology cannula is inserted.
Will you put in a vent?
Yes, sir. After the root cannula, I will insert the vent, sir.
Where?
Cardioplegia root vent would be just enough space for the cross clamp. Between the root vent is inserted, just having enough space for the cross clamp, sir.
Why would you need a root vent? You're opening the aorta.
Sir, it is an aortic stenosis case, sir. My left ventricle will not be vented in this situation.
So you put a root vent. Or
root
where
vent first
vent
for the
site?
cardioplegia, sir. But the root vent is for the RSPV, sir. Right superior venous.
RSPV. So why do you need a cardioplegia, cannula there? You can open the aorta and do directly intracoronary.
Yes, sir. That is one option. Yes, sir.
It is better. In aortic valve, it is better because you will do it under vision.
Yes, sir.
All right.
Yes, sir.
In any case, you are opening the aorta.
Correct. Correct.
So these things should be kept in mind.
No, but still, many surgeons, it was pure aortic stenosis. They give the first cardioplegia through the root, If there is no, it's much easier because the severe calcification, the coronary vasculature, or almost the calcium jetting in. Pure stenosis, many of us used to do root cardioplegia, Krishna. If it's AR also, then of course, open and directly calibrated. Okay.
Yes, sir.
Proceed. Yeah, proceed.
Yes, sir. RSPV vent is inserted, sir. RSPV vent insertion technique where we take a purse string, we fill the heart, make sure the PA is full, and then stab the RSPV with 11 number blade, insert the vent and direct it to the LA. Via TE guidance, we can direct it to the LV, sir. We ensure this, it is height
Before the TE guidance, how we used to do that?
Sir, if there is bright blood coming out of the with every ejection, there is a bright blood coming out through the vent.
No,
It is a,
no. I asked how are the steps you do that?
steps as such. Sir.
Yeah,
How do you insert it?
yeah.
The cannula is
How do you insert
right
and
angle.
direct it to the LV?
Yes, sir. The cannula comes with a stillet, which is flexible stillet, and we bend it to the right angle and then insert it to the LV. We guide it towards the
You know,
mitral
that's
annulus.
not. It's a very dangerous procedure to do that with a stillet. You
Okay,
may
sir.
perforate the LV. We all used to put your right hand behind the heart onto the left atrium. Feel the left atrium in the oblique sinus, You can actually feel that. And then this without stillet, after putting it into the LA, you use the left hand to push it and the right hand in the
To guide
oblique sinus behind the left atrium. You can guide it to the left ventricle. Be careful. But
Yes, sir.
I don't think it's a good idea to put the stillet to that. You
Okay.
100% may perforate the left atrium posteriorly. Okay.
Yes, sir. Cardioplasia is delivered, sir. In this patient, I would be using del nido cardioplasia.
what's the
Proper
composition? How does it differ from St. Thomas?
sir. One is that there is the potassium content in cardioplasia is lower in case of del nido, and there is low calcium in del nido. There is a membrane stabilizing property in del nido that prolongs the time of myocardial protection to almost up to 60 to 90 minutes, whereas in St. Thomas solution, which is a hyperkalemic and hypercalcemic solution, which arrests the heart for a temporary 30 minutes and requires frequent redosing. And here
Okay.
acceptable redosing time is around 30 minutes for St. Thomas and 60 minutes for del nido cardioplasia.
So routinely in your institution, you use Del Nido for all cases?
No, sir. Different surgeon ask for the different ones based on the procedure. In case of single valve replacements, some surgeons prefer to use St. Thomas, whereas some others for double valve replacements prefer to use Del Nido for longer cross clamp time.
Del Nido was introduced for children cardiac surgery in Boston children, or Del Nido, and it's extended into use for adults in many places.
Yes, sir.
Okay.
Now I will cross clamp the aorta. Before cross clamping, reduce the flows, insert the cross clamp without taking the pulmonary artery in the jaws, tighten the rashets one by one very slowly. Sir.
Do you tape the aorta before or not? Is that practiced in your institution?
No, sir.
Some of us used to make a space between the PA and the aorta and then tape, if necessary, tape it and then give the, and then put in the clamp.
Yes, sir.
Then second thing, is it a protected clamp? It may not be required in a younger patient, but in an elderly patient with calcified aorta, you may need a clamp which has got a sleeve or a buttress. Do you think, do people have it here? Do people have a aortic cross clamp with a rubber guard?
No, sir. No, sir. Only for the MICS, we'd use something called a signet clamp, and that comes with a rubber guard and the jaws.
So these are things that you should be aware of. Yeah.
Yes.
Okay. Anyway, tell us what you do normally.
Even if you don't tape the aorta, it's always a safer. What I found is to dissect out between the pulmonary artery and the aorta and separate it little bit. Because in case your aortotomy extends, because in aortotomy, the angle of sorrow is actually the right side or the right side end of the aortotomy if it extends, and
Yes.
on to the left side is the pulmonary. So it's a very good idea to dissect the tissue pericardium between the aorta and the pulmonary artery, even if you don't tape the aorta so that the angles can be secured, because bleeding from the angles is often difficult to control.
Yes, sir. Sir,
What
followed by
happens if you clamp both of them together, both the PA and aorta, in the transverse sinus?
actually not much problem, sir. We'll not have the returns coming from the LA. But then if we are extending the incision, like sir is saying, it may come into our way and we
Correct.
cannot release the cross clamp at that time.
Correct. That's important to know.
Yes, sir. So followed by this, I would do a J-shaped aortotomy, one finger or two finger above the right coronary ostia. And in other approaches would be an oblique incision where it opens for with a bigger size and exposure. It is preferred for beginners because later on traction and retraction of the aortic wall may lead to shear stress and cause more damage. If we open less, this will be a problem.
This
Once
patient's
the,
this patient's aortic annulus is 19.
yes, sir.
Does she require a root widening or not?
Sir, according to our body surface area, 18 to 19 is what they had suggested. So in this situation, we may not require, but in other cases where the body surface area is larger, then we will definitely require a root widening procedure for this patient.
Okay. In sometimes the examiner may ask you what are the different types of root widening. So
Yes,
you must
sir.
be aware of that.
Yes,
Okay.
sir. Yes,
The
sir.
simplest is the Nix, then
So in
Manosian,
this,
and then Kono.
Yes,
so
sir.
in this case, you need not have done a J-shaped incision. Rather, a low transverse artery would have been enough. Anyway,
Okay.
that's not very important because
What's
you're
the
not planning
advantage
to.
and disadvantage of these two incisions? What is the advantage of a transverse incision and what's the advantage of a J shape and disadvantages of a J shape?
Sir, lower transverse incision, it gives us a wide access and visualization for the aortic valve. Easier for us to access the aortic valve with the calcium debridement. But a J-shaped aortotomy would be helpful if I have to plan for a root widening procedure where the incision does not come in the way.
Good. Okay.
But here you're not planning, so transverse incision would have been better because your
Yes.
visualization is absolutely good. Once
Yes.
if you take a hitch around the commissures, the whole valve is in front of you.
Yes, sir.
And what's the disadvantage of J shape? The inferior, this thing is way down. So when you're closing, you should be very careful that you take the stitches beyond the incision area so that otherwise you will have bleeding from that area.
Yes, sir.
And you keep on taking plugate, and then a whole lot of things and then get into more and more trouble.
Yes, sir.
So you have to be, your closure has to be pakka when you do a J-shaped incision.
Yes, sir. So once I visualize the valve, I see that there is calcifications on the valve leaflets as well as the annulus. First, I would go towards the NCC RCC commissure, the right non-coronary cusp and the right coronary cusp commissure. That is where I would like to start my excision from. And then I would go anti-clockwise and clockwise and excise the valve leaflets. And if there is any valve leaflet that is not affected, that would be my first choice, because once that is the excised, I may be able to put a wet gauze piece into the LV cavity so that it protects from all the calcium debris that is entering into the ventricle.
That will be more correct than saying you start with the non-coronary or the right coronary. It's always the least calcified to start
Yes.
with there to get an access for you to put a wet gauze piece into the left ventricle to catch the calcium debris that may fall.
Yes,
Yeah.
sir.
And also somebody, your assistant should close the left coronary orifice because that is the most dependent area from that area. So
Yes,
with
sir.
a peanut or something, you should close it. Make sure that the calcium doesn't drop down into it.
Yes, sir.
What do you use for decalcifying the valve?
Sir, we use an instrument called the rongeurs, which helps in breaking down the calcium and removal of it, sir. Once my decalcification is complete, I'll take a gauze count. I'll wash the LV left ventricle with saline at least twice, sir. And then now I would size the valve, sir. Once the valve sizing is done, I would take sutures. Essentially, with pledget sutures is what we are trained here, with the pledgets facing the aortic end and not the left ventricular end. So simple mattress sutures are taken in this.
Before that, you take the 3 commissural sutures.
Yes, sir. Started with
You
3.
have to pull the aortic annulus up into your view and then take the annular sutures.
Yes, sir.
You call them the transverse everting matter sutures because
Yes, sir.
when you drill it that from the aortic side, it becomes an everted thing when you pass it through the skirt of the valve,
Yes, sir.
Everting matter sutures with blood jets.
Yes, sir.
If the annulus is borderline and your valve is you're just able to fit in a 19 mm valve, how would you save? Because everting sutures will reduce the annulus a little further.
Yes, sir.
How do
In a,
you prevent that and how do you manage that?
sir, in a situation where I don't have to do a lute enlargement, but to give a proper sized valve, I would do a thorough decalcification, clear all the rims around. Pledgets are placed in the ventricular side in such situations, or it can also be done without pledgets. And also simple sutures also help in these situations.
Yes, simple sutures, one single pass simple sutures will occupy less space. Or from the LV side.
Yes, sir.
I don't know whether you do that nowadays. We used to have a top hat type of valve,
Yes, sir.
where
Super.
it sits supraannular. So
Yes,
you
sir.
put your pledget from the ventricular side, you come through that, So
Yes.
the valve actually sits not at the annulus but supraannularly.
Yes, sir.
Is top hat available nowadays?
No, sir. Nobody is using.
Okay. Top hat used to be a good valve.
Yes, sir. Once my all my sutures done, my valve is seated well. Once and all the sutures are tied, making sure none of them are crossing the valve. The sutures are not stuck to the housing or the struts of the valve. And once the valve is seated and tied, I will make sure that the valve is opening properly by a valve tester. Sir.
Is this a rotatable valve that you are using or a fixed valve?
So in this patient, we were using Chitra valve, sir. It is a rotatable valve, single leaflet tilting disc valve, sir. It is rotatable both sides, sir.
What the disc in Chitra valve?
Sir, it is a polytetraphthalate.
That's not the correct thing. I thought expected better from you. Ignorance, ultra high molecular weight
Molecular weight.
polyethylene. Yeah.
Yes, sir. It's a polyethylene. Yes, sir.
Yeah. Okay. All right.
What was the original disc?
So right now we are using the 4th generation Chitra, sir. The first generation I don't remember, sir.
You should know.
Yes, sir.
It was a sapphire disc.
Sapphire disc. Yes, sir.
And then slowly a lot of other this thing, it was prone for fracture. So then they started modifying it. And then now it is an ultramolecular
Yes, sir.
polyethylene, I think.
Yes, sir.
Ultra high molecular weight. Yeah.
Yes, sir.
Okay.
Once the
What
valve
is
is,
the orientation of the valve?
sir, my larger orifice area is towards the greater curvature of the aorta, sir.
Yeah.
And the opening should not be directed directly towards the ostia of the coronaries.
You have to make sure that the valve is seated subcoronary, both sides,
Subcoronary.
the right and left. Yeah,
Yes.
you should be able to see the coronary orifice well. Supposing you're doing a double valve, what will you do?
Sir, first excise the aortic, then excise the mitral, replace the mitral, and then replace the aortic valves.
Yeah, you will have to, once you excise the aortic and you have sized the valve, you do the mitral and come back and resize the valve.
Yes, sir.
Remember to resize the valve before you put in the aortic valve
Yes, sir.
when you're doing a double valve.
Yes, sir. Aortic closure is done in a double layer fashion with a 4 polypropylene suture, sir.
Continuous, interrupted. What do you mean by double layer?
Sir, the first layer is in a continuous buttress fashion, sir. The second layer would be a continuous suture, sir.
Don't say buttress fashion.
It is called
That doesn't-
horizontal mattress.
Horizontal
Continuous
mattress.
horizontal mattress, and then this thing, and you have to take care of the corners of the incision.
Yes, sir.
Most important in any incision, whether it is in the skin, LA, aorta, bronchus, anywhere, it is
Yes, sir.
the corners should be taken care of properly.
Yes, sir.
What is the exact technique of passing that at the corner? I used to
Sir.
insist on that.
You always pass it inside out.
What I mean exactly. You go inside the aorta, and
Yes,
then
sir.
you can go much more beyond the corner. If you try to come from outside, you don't get that much. So you put the first needle from the aorta as far as possible outside, and the
Yes, sir.
second needle. That's a technique to make sure that the corner is. Then you put a master sutures.
Yes, sir.
Usually you start from one end, probably the right hand side, and use another suture from the left side and come to the middle actually.
Yes, sir.
Okay.
Why do you do that?
So that the corners are firmly approximated to each other, sir.
Yeah, but why not one in a come from the lower down and then come up where the other corner is in front of you? Why do you need two sutures? Before you tie this, say the two sutures in the middle at the top, that is the most superior portion of the aorta, and that can be used for de-airing as well when you're.
Okay.
Fill up the heart, fill up this thing, and so that the blood comes out through the middle, and then you tie it.
Okay, sir.
And then also the other reason is that there is uniform tension from one end to the other.
Yes, sir.
You tie it in the middle.
Yes, sir.
Otherwise, you will form a dog ear in one end.
Yes, sir.
So these are two reasons why you do that with two sutures.
Okay, sir.
And the second is a continuous layer,
Yes, sir.
which is not going beyond the matter sutures, you know. Okay. Okay.
How do you
There
come
are
off?
other-
Yes, sir. Once my aortic closure is done, my de-airing process begins. One is through what is we are routinely using is a pericardial CO2, carbon dioxide infusion. Right side de-airing is done manually with lung ventilation, and left side there is a root suction on, and the LV vent is left on gravity. The way we do the de-airing is that the left hand is kept on the LA appendage, and right hand is kept. Sorry, the left hand is kept on the LV appendage, the thumb on the LV coronary orifice and compressed, and then it is de-aired gently with the entire ventricle along with the apex as well. Since it is an aortic stenosis case, we can do our this kind of technique of de-airing.
every case you do carbon dioxide insufficiency or only in minimally invasive.
No, sir. Most of the cases nowadays we are doing it, sir.
Okay. We were under the impression that minimally invasive is absolutely necessary.
Yes, sir.
Filling the heart, and also these days you got TE, you know, so guided by the TE also.
Yes. So once this is done, sir, I would be preparing for releasing of my cross clamp. Before I release, I would put the patient on head down position. Anesthetist continues to manually ventilate to de-air the pulmonary artery as well as increase the left atrial blood inflow. Uh, the moment we do the head low, the aorta gets filled up, sir. Root is put on suction now, and then we release the cross clamp, ratchet by ratchet.
You don't want to rewarm the patient. You don't want to get the temperature up. You don't want to check the electrolytes
Yes, sir.
before releasing all this.
Yes, sir. The moment we finish our aortotomy closure, we ask the perfusion team to start rewarming the patient, sir.
You forgot to mention that.
Yes, sir. Yes, sir.
That is why I tell you, I insist that you should write all these steps
Yes,
so that
sir.
you don't forget each one.
Yes, sir.
Right. So all of you will write the entire steps of AVR today, so that when and then you should know when the examiner, even you'll definitely get one aortic valve or a double valve, and then
Yes.
they will ask you the steps of AVR. Then you should
Yes.
know these things, and then there is no point, no excuse for forgetting a step.
Yes, sir.
The patient is at stake. Yeah. And will you start an inotrope or not an inotrope? What is your protocol in your institution?
Here, sir, it is an aortic stenosis with an LV hypertrophy. We may be able to come off with, and coronaries are normal. We may be able to come off without any inotropic supports. Meanwhile, we do keep the infusions at 0.1 ml just in case we need it.
Yeah. Most people usually come out with a very low dose in inotrope and then quickly wean it off.
Yes, sir.
Right.
What about retrograde cardioplegia in this case?
So since the coronaries are normal and we are able to access the ostia directly, retrograde cardioplegia may not be needed, sir.
Yeah, it's not needed actually. Okay.
Yes, sir. Yes, sir. Once the heart is returning back to normal and sinus rhythm once we ensure that the parameters are normal and the ECG is returning to normal with good LV contractions. Temperature is normal, ABG is normal, and potassium is normal. We usually ideally wait for a minimum period of 10 minutes to 15 minutes. Once all that is done, we proceed with removal of the LV vents.
What are the problems that you can encounter coming off bypass?
Sir, one major thing is that it may not, we may not return back to sinus rhythm, or we may be having very poor ventricular contractions.
Why?
Sir, if, returning not to sinus rhythm, surgical causes maybe if we have, if the calcium is too close to the atrioventricular node, or we have taken a suture at that area for the seating of the valve, that may lead to a conduction block for us. And if there is potassium abnormalities, especially hypokalemia, this may lead to returning of the sinus rhythm in atrial fibrillations as such.
Okay. Why do you get LV weak, this thing, LV contraction?
Sir, in case we have not given adequate cardioplegia, in case we have missed an aortic regurgitation while giving our root cardioplegia, or in case we have forgotten a coronary artery disease and left it saying it was not significant.
In short, you say poor myocardial protection.
Poor myocardial protection. Yes, sir.
So generally in a pure aortic stenosis with a hypertrophic left ventricle, you would generally give about 10 to 20% more cardioplegia.
Yes, sir.
Okay.
Yes, sir.
That is one. And secondly, when you are coming off, you give a little more rest to the heart.
Yes, sir.
beating heart. Okay. So normally we used to say that we support it on bypass for 1/3 the cross clamp time.
Yes, sir.
I don't know what is the present teaching. I don't know what you all do.
Yes, sir.
Is that what you do?
We keep it at least about 15 minutes post clamp removal, sir. We keep
Whatever,
the PT.
15 minutes, whatever your duration of clamp time is.
Yes, sir.
Okay.
So once we remove the LV vent, and then we go back to the root vent and remove the root vent. Yes, sir.
Many of us used to, okay, as Jairaj sir said, we did the root cardioplegia earlier, then you do an aortotomy. So at that point of time, we would remove the root vent and then reinsert it while just coming off after closure of the aortic suture. So that is something that many surgeons practice that way.
Yes, sir.
Yeah. And then take it off after coming off bypass, right?
Yes, sir.
So de-airing is very important in these cases.
Yes, sir.
And sometimes if you're another problem that can happen when giving you difficulty in weaning off bypass is one is rhythm, one is poor LV myocardial protection, third is calcium in the coronary arteries or air in the coronary arteries.
Yes, sir.
These are the four things that can happen to give you problems coming off bypass.
Yes, sir. So once we are ready and ensure that the with the TE guidance, we ensure that the myocardial contractions are good and the valve opening is good and there is no paravalvular leak, we start coming off gradually. And then once we finish coming off completely off the flows, we administer protamine to reverse the heparinization. At around 50% of protamine dose, we are going to remove the right aortic cannula first, followed by the right atrial appendage cannula, right atrial bicaval cannula.
Is that right? You remove the venous cannula first or the aortic cannula first?
Sorry, sir. Aortic venous cannula first, followed by the aortic. In case we had to give more
Yeah.
fluid due to protamine
Yeah,
reaction.
you can't make that mistake, sir.
Yes, sir. Yes, sir.
Okay.
Yes, sir.
Post-op, what are problems you can expect?
Post-operatively, the first important one would be bleeding is something of my concern. Second,
Second is rhythm.
yes,
Third
sir.
is LV function.
Yes, sir.
Okay. Would you like to put a pacing wire or not?
In this situation, I would like to put a pacing wire, sir. RV pacing wire would be put in this.
But you have closed the sternum already. How will you do that now?
Yes, sir. I forgot to mention, sir. I should have
Ah,
mentioned.
there are many things you forgot.
Yes, sir.
Huh? The many things you forgot and the patient is in trouble. Sorry, sir, I have to go back in and put it back. That's not correct. Understand?
Yes, sir.
So your sequence of steps has to be very, very clear.
Yes, sir.
That is why you have to write it down and literally by heart those steps.
Yes, sir.
You got four or five operations, you should know them thoroughly. So you generally do a pacing wire most of the time, especially in aortic stenosis,
Yes, sir.
so that you have a backup. Okay. What else you want to tell us?
Sir, about the valves we use, sir, because it is most commonly asked. This is the slide that have been prepared, and they contain only information about the valves, how we have to present the exams.
Very good. Yeah.
So I'm going to speak about only the valves which we are using at our institute, sir. Mechanical valves, bileaflet valves being the Onyx valve, St. Jude valve, carbomedics which are right now being used, tilting disc valves, Medtronic all, and TTK Chitra. And only TTK Chitra is something that we use as a tilting disc valve, sir.
Do you mean to say we use Medtronic or valve? No.
No, sir. No, sir. I just mentioned it. Only TTK Chitra is our tilting disc valve here at
No. Medtronic or valve was discontinued in 2009. The production was discontinued. I used to think it is a fantastic valve, and we used to put a lot of them.
Yeah.
In 2009, they have discontinued the production of Medtronic valve.
Yes, sir.
They have now shifted completely into the transcatheter valves. They don't produce it anymore.
Yes, sir.
But if I remember right, sir, Medtronic Hall used to come in 20 millimeters also.
Yeah, 20 millimeter also.
Yeah, so that used to be a better option than putting in a 19 mm.
19. Okay.
Yes, sir. So first we are going to discuss about the TTK Chitra valves, the most commonly used, the first indigenously developed heart valve for the Indian population. It was developed in Sri Chitra Tirunal Institute of Cardiac Sciences by Professor Valiathan. TTK means TT Krishnamachari. It is the company. And 1976 was the first developed, and 1996 got the first approval. Currently, what we use is the fourth generation valve. And sewing ring is made up of polyethylene terephthalate. Disc is by high molecular weight polyurethane. Cage is by cobalt chromium alloy. There are three struts, two major and one minor. The two major exist at the below of the valve, and the one minor is on the above the valve. The opening angle is close to 72 degrees. It is a rotatable sewing ring to reorient the valve. Better than the bileaflet valves, it operates in silence. One of the physiological advantages for these is central blood flow, decreased turbulence, and reduced shear stress. The difference between the aortic and the mitral valve is that in the aortic valve, the valve opening is above. In the mitral valve, the valve opening is below. This is about TTK Chitra, sir.
What do you mean by operate silently?
Sir, where there is a valve tick, which is very typical in case of bileaflet valves, it is not so much in this, sir.
Yeah, because this is a polyethylene material,
Yes, sir.
whereas bileaflets are all pyrrolite carbon.
Pyrolytic carbon, yes, sir.
So they go onto the housing, and then
Yes.
they cause a lot of noise
Yes.
as a click.
Next, we are going to discuss about the Onyx valve, sir, developed by Medical Carbon Research Institute, USA. The current used is the latest generation with optimized design. The sewing ring is Dacron or polytetrafluoroethylene, PTFE sewing ring. Leaflet is pure pyrolytic carbon, microlamellar structure. The housing is also pure pyrolytic without any silicon mix. This differentiation is important when we discuss the St. Jude's valve, where there is a silicon mix. Design is that this is a bileaflet valve with actuated pivot mechanism. The opening angle is 90 degrees, which is highest among all the bileaflet valves. Closing angle is 25 degrees. The importance with the opening angle and the closing angle, opening angle, the wider the angle, the smoother the outflow dynamics. The closing angle, the lesser the closing angle, there is lesser amount of platelet aggregation and thrombogenicity properties. Unique features about the Onyx valve itself, it has a flared leaflet tips which enter partially into the LV cavity. This helps the valve leaflet get washed by the blood as it moves. There is a 2-point contact housing and the sizes are 25, 27, 29. All of them come with an effective orifice area which is similar. It operates with an audible click. Physiological advantages which are claimed is that blood initiates the valve closure itself. That is the actuated pivot mechanism. Superior hemodynamics even with lowest gradients. There is reduced thrombogenicity, decreased hemolysis. The company claims that the INR could be targeted with 1.5 to 1.8. And some of them also say it is not necessary to anticoagulate, but still in our institute, we still target the same range as for the aortic, which is around 2 to 3 INR.
What is the major difference between St. Jude and Onyx?
So one thing is that there is pyrolytic carbon is a silicon mix when it comes to St. Jude's, and the opening angle, sir, which is
No, I think the most important thing is the hinge point of the leaflets.
hinge point.
In the St. Jude valve, it is a fixed hinge point, and
Yes,
that
sir.
causes problems with the thromboembolism and,
Yes, sir.
and prone for clot formation. Whereas in Onyx, there is a movable hinge point so that it gets washed out easily.
Yes, sir.
There is no fixed hinge point. This is very important in the design.
Yes, sir.
And that is why you are able to maintain a low INR.
Yes, sir.
Because there is no fixed point there.
Talking about the St. Jude valve, sir, developed by St. Jude's Medical in USA. The sewing ring is again made up of Dacron or polytetrafluoroethylene, PTFE. The leaflets is pyrolytic carbon. The housing is pyrolytic carbon with the silicon composite mix. The design is that there's a bileaflet valve with butterfly pivot mechanism. The opening angle is 85 degrees compared to 90 degrees in the Onyx valve. Closing angle is 30, which is almost highest at along the bileaflet valves. Unique features is that it was the first bileaflet design with 2 semicircular orifices. The butterfly hinge creates a very acoustic shadow on the echo post-operatively. Physiological advantage, central flow with low profile design, good track record and has more than 40 years of clinical data. Physiological disadvantages in mitral position, it has an incomplete washing, as you mentioned, sir. This leads to increased thrombogenesis risk. The material, the housing material is along with it is not pure pyrolytic carbon and leads to a smoother, more smoother, which is more smoother. Here it is more rough than this one, sir. It may increase the platelet activation.
What is the history of the St. Jude valve? Do you know?
Uh, yes, sir. It was about a saint. I'll just.
No, sir. St. Jude valve was developed in Minnesota by Lilly High, and the other person who actually literally designed the valve was one Indian surgeon called Kalke, PR Kalke from Mumbai, who was working with Lilly High in those days.
Okay, sir.
So, and as it always happens, the brown or the black person's name gets obliterated even when
Yes,
it
sir.
comes to literature, right?
Because in literature they have mentioned about some Danny Thomas and they have given this monk's story.
No.
Yes, sir.
It was done in Walton Lilly High's unit, and B.R. Kalke was the person who was involved with the design, isn't it, sir?
I don't know whether it was about the St. Jude or some other valve. This guy casted. I'm not sure, He was involved. I know he was
And I think it is St. Jude, sir.
because
Bileaflet. His was the
but
first
the
bileaflet valve. I mean, that design was from
because
Kalke.
the St. Jude was introduced only in 1977 or something.
Sir, for a few years, which is close to 2 now, we have been using the bicarbon carbomedics valve developed by Sorin Biomedica from Italy. Sewing ring is again from PTFE. Leaflets are pure pyrolytic carbon. The housing also is pure pyrolytic carbon. The design of the valve is that it is bileaflet with standard recessed hinge mechanism. The opening angle is pretty lowest. Closing angle is 25%, 25 degrees. Unique features, it is central rectangular jet with two peripheral semicircular orifices. We have three orifices. Because of this, the opening angle is also less. They have a normal hemodynamic profile and excellent hemodynamics despite lower opening angle. Operates with an audible click. Low turbulence reduces the blood elemental trauma. Low closing angle decreases platelet activation in the patient. These are the bioprosthetic valves. Majorly, we classify
Hold
them
on,
in.
hold on. Just before that, I wanted you see the deficiency in this presentation was that you didn't talk about the effective orifice areas of all these valves.
Yes, sir.
Second,
Yes.
second, the incidence of thrombogenicity in all these valves. These are important things to know
Yes, sir.
when to choose what valve. All right. So that is something that you should know,
Yes, sir.
especially if when you're using the difference between a tilting disc and a bileaflet valve. What is the flow pattern, hemodynamics, and the flow pattern of the blood through the valve? And where is there is a primary orifice, there's a secondary orifice in a tilting disc, and then there is lateral laminar flow through the bileaflet valves.
Yes, sir.
So these are also an important consideration when you're choosing a valve for a particular patient.
Yes, sir.
Effective orifice area is most important.
Yes, sir.
If St. Jude's valve was so good, why did Narayana there change from St. Jude to carbomedics valve?
Sir, here we got to know that
Money.
money. Yes, sir. The pricing suddenly and abruptly increased.
Yeah,
Yes,
it's
lower.
purely commercial administrative decision. Okay.
Coming to the bioprosthesis, sir. we have two types, which is bovine bioprosthesis and porcine. When it comes to bovine, we make the valve is made with the valve leaflets are designed with the pericardium of the uh, bovine pericardium and aortic valve leaflets of the porcine is what is used for making the porcine valves.
What's the difference between a porcine aortic valve and a human aortic valve? This is a standard question by examiners. How is it different? The porcine, the right coronary cusp has a muscular bridge below the right coronary cusp in the porcine valve. So many a time they excise this right coronary cusp and suture another additional leaflet and fixed at 0 millimeters pressure.
Yes, sir.
So that to prevent calcification and to prevent disruption.
Yes, sir.
So you must know. And then you also should know a little bit about tissue engineering, the decalcifying processes in the various valves. And then again, as we mentioned, effective orifice area and the flow patterns.
Yes, sir.
The use of porcine aortic valve was discontinued long time ago because of the muscular bridge on the leaflet. So earlier stage, I think I remember they used to have a modified orifice. That means you remove that cusp with the muscular bridge and get from another pig the stone and put as a modified. That's all given up now. Most of the valves nowadays are pericardial valves, and that too bovine pericardial. All the best recent valves are all bovine pericardial.
As soon as you finish how much, you have to put the balloon for a steady solution.
Yes, sir. The two main valves that we used is Edwards Magna and Hancock bioprosthesis. Hancock bioprosthesis manufactured by Medtronic. It's a porcine valve. Pre-implantation technique is with glutaraldehyde fixation. The tissue is preserved in glutaraldehyde solution at zero pressure. It cross-links collagen fibers while maintaining natural valve architecture. It preserves the natural porcine valve geometry and structure. It prevents immunologic reaction. It maintains flexibility and compliance of native tissue valve, and biologically inert properties are engaged. It undergoes anti-calcification treatment with a proprietary chemical treatment to reduce calcium binding sites and reduces structural valve deterioration rates.
Yeah.
What do you mean by zero fixation?
Sir, in the preservative, the leaflets are made just to float, sir. They're not fixed with any high atmospheric pressures.
No,
the preservative
I think the fixation to the sewing ring is that the pressure, there is no pressure difference between the inflow and the outflow. So from the ventricular side or the aortic side, that is what it is called zero fixation.
Okay, sir.
I think that is what it is, but you better check on it, you know.
Yes, sir.
So what do you mean by zero fixation? There you have mentioned somewhere at 2 to 4 millimeter pressure fixation. So find out what it is all about.
Yes, sir.
You said everything except the strength of the glutaraldehyde.
Sir?
You said everything except the strength or the percentage of the glutaraldehyde solution used for fixation.
How much is the strength?
Sir, 0.6% glutaraldehyde.
0.625.
Yes,
and then you should also mention that this has to be washed in normal saline before you implant it.
Yes, sir. In this slide, I'm talking about pre-implantation rinsing, which is mandatory. Valve is rinsed in 3 separate basins of sterile saline or Linger's lactates for 2 to 3 minutes each. It removes the residual glutaraldehyde preservative. It is toxic to the tissues. It prevents chemical-induced myocardial depression. It reduces inflammatory responses. And we should avoid touching the leaflets directly when we are handling the valve, and only the sewing ring should be handled. Uh, yes, sir.
So what are the differences in implanting a mechanical valve and a tissue valve? When you're putting in a tissue valve, what are the pros and cons? What are the differences? You should know.
So the advantages and disadvantages of the mechanical versus bioprosthetic, sir, or intraoperatively how we differ in implantation.
Intraoperatively, what are the measures? How do you do? What are the important steps?
Yes, sir. For bioprosthetic valve, tissue handling is very important, and rinsing of the valve is important, and orientation of the valve is anatomical position in case of bioprosthesis, and suturing technique is almost similar in both of them, sir.
Suturing technique is similar, but when you're tying, you have to be very careful that you don't damage the leaflets on the bioprosthesis.
Yes, sir.
As you're pushing your finger down to tighten the knots.
Yes, sir.
And in a mechanical valve, they can get caught with the leaflet and other things. So
yes.
if it is long, you have to be very careful. Second, testing the valve is important. You have to be very, very gentle doing testing the bioprosthetic valve, because you have to open the leaflets and see whether you have left any loops on the ventricular side.
Correct, sir.
So that is important. And in the mechanical valve, you have to be when you're testing the valve, you have to use a non-metallic instrument.
Yes, sir.
Which is a soft thing, so that you open the leaflet and then look inside on the ventricular side. You must always make sure that you don't leave any loops which can cause loosening of the valve sutures and cause paravalvular leak.
Yes, sir.
That is another thing that you should know, the differences between mechanical and bioprosthetic valve, the incidence of hemolysis that occurs.
Yes, sir.
With the valve. And then there is something that is called inherent regurgitation and opening angle. Just before the valve closes or opens, there is some amount of regurg that happens through the valve orifice.
Yes, sir.
Okay.
Sir, there was another slide I made for Edwards Magna, but it is missing, sir. I'll just.
Okay. Fine.
That is a bioprosthetic valve made out of bovine pericardium, sir, with a stenting frame outside, nitinol stenting frame.
Okay, for my curiosity, what is the pricing of these valves nowadays?
Sir, Hancock bioprosthesis is somewhere close to around 1.5, sir. That's the least that is costing. The Magna goes up to 3.2. There are now sutureless valves coming for Percival valves, which is being used for aortic. That is causing close to 3.8 to 4.2 based on the patient's request. We have been doing Percival valves and we have done around 3 till now, sir. All three sutureless aortic valve. So they are costing around 4.2, sir.
How much does a TTK cost?
Sir, it is around 25,000 to 35,000.
Yeah, see the difference, my God. And St. Jude and Onyx?
St. Jude not coming at all, sir. Onyx is close to 1.2, sir.
Okay. All right. Any other comments, sir?
No, very good presentation, excellent. Thank you. But didn't you read anything about in your extensive reading about the Resilia valves, which I thought are fantastic
Yes,
ones?
sir.
And
Yes, sir.
the
They are supposed to be the
Resilia for mitral and Inspiris Resilia for
Cecilia for
aortic,
aortic
they have got better uh,
duration and long.
ratio of the annulus ratio and less
Yes,
uh, patient prosthetic mismatch. Didn't
yes, sir.
Why didn't you mention anything about the mitus recilia and the inspiris recilia?
Yes, sir. Yes, sir. By far, it's the most costliest valve available, sir, and we also utilize that valve here.
Okay. But it's supposed to be very good in literature, I saw. Okay.
Yes, sir. It is promising at least 15 years of duration.
Yeah.
You must make a sort of a table of all the comparison of all these valves
Yeah.
of various features. Okay,
Yeah.
so that you have a ready reckoner before going
Yes, sir.
for an exam, so that you can just look at it and say what are the pros and cons of each valve.
Yes, sir.
Okay, that is
Yes,
something that you should do.
yes, sir.
When you insert the bioprosthetic on the mitral, you have to be much more careful. It's very likely that one of the sutures may get caught on the struts.
Yes, sir.
Aortic
Yes,
valve is you are right in front of your view. But mitral, there's a chance you have to be careful.
yes,
You
sir.
have to, when you
Okay, thank you.
you, you said the anticoagulation. Of course, anticoagulation in onyx valve is different on aortic and
Mitral
mitral.
position.
You said you keep 2 to 2.5 in our hospital, is it?
No, sir. 2 to 3 here as routine itself, but the company claims you can keep it to 1.5 to 1.8.
Yeah, that's what I thought. I don't know why we keep it 2. I thought it's always better to keep it around 2 rather than 2 to 3. Then you lose some of the advantage of the lesser anticoagulation and the more chances of bleeding. I don't
Yes,
know
sir.
we
We,
did that.
we normally used to do 2 to 2.5 for aortic and 3 for
Yeah, yeah, that's all. Because the Western standards is much more. The mitral, they say 3.5 to 4.5. We never
Hmm.
keep that way now. I thought roughly 2 for aortic and 3 for mitral. And the
Yes.
next, they say even 1.5 to 2. So average, I'll say 2. Okay. Okay. Oh, yeah.
Acha, Karan, what is your post-operative anticoagulant regimen? For how long will you continue this for individual valves?
Yes,
And
sir.
what do you do in a double valve?
Sir, in case of a double valve, we keep the anticoagulation at 2.5 to 3.5 itself, and this will continue lifelong. And in case of bioprosthesis, we are able to manage in mitral position. We definitely keep a blanket dose of 2 milligram warfarin or 1 milligram warfarin based on the body weight of the patient, and for 6 months. And after that, we can only keep them on single antiplatelet therapy. And for aortic position, usually it is not recommended to keep any warfarin, and we can keep only single antiplatelet therapy like ecosprin, aspirin of 75 milligrams. And in case of patients with who are planning to conceive pregnancy, the regimen entirely changes, where we are going to bridge with heparin in the first trimester and completely keep them on heparin till the second trimester end. Third trimester can be switched back to warfarin post before delivery, and at least till 2 months or 3 months post partum, we keep them on low molecular weight heparin injections, subcutaneous fragment injections. Thereafter, resume back to warfarin. Sir. The warfarin does enter through the breast milk to the fetus, but it is not found to be any causing any damage to the fetus as such. Sir. It is only a teratogenic drug which can cause during the development of the fetus.
That has been overemphasized. I have never seen a warfarin embryopathy in my life till now. And most of the time, patients are not even aware that they are pregnant in the first trimester. So when they will, you have no chance to convert them to heparin and then go back to oral anticoagulants in our population. That is something that is a practical thing that happens in our country. The reason I asked you is how long in a mechanical valve. See, the standard, there was a little controversy about this. Standard thing teaching was you will continue anticoagulation for 5 years or 40 years up to the age of 40, whichever is later. And then some people continue it lifelong. In a double valve, it is usually given for five years because you have replaced both the valves, and the chances of reactivation of rheumatic fever is much less. That is the argument that was given. But I don't know what is the present regimen that you people are using. I don't know.
Here we continue lifelong only, sir, as such for all the patients.
But are you sure they're taking lifelong? We don't know because we don't have that sort of follow-up in any of our patients. Okay, so that is something that you should know because there is a controversy about the management of anticoagulants in the post-op period.
Yes.
So look at the literature, look at this thing, look at other units that are in the country and what people do.
Yes, sir.
Because your examiners are from different places, so they may have different ideas.
Karan, did you say you will continue rheumatic prophylaxis till the end of the life, is it?
No, sir. We never talked about rheumatic prophylaxis, sir.
Krishna was meaning that. Krishna was meaning that actually. 5
Yes,
years,
sir.
40 years. And
Yes,
I
sir,
used to think that after double valve replacement, we stop rheumatic because
rheumatic prophylaxis.
because
Yes,
both
sir.
valves are gone, you know. So all that you can get is some pericarditis or myocarditis. That used to be my interest. It does not anticoagulate. You're
Yes,
speaking
sir.
about the rheumatic prophylaxis.
Yeah, rheumatic. Yes.
What about combining aspirin with anticoagulants for a prosthetic valve?
No, sir. I don't have much idea about that.
We used to say in some cases, you know, we give warfarin. That time we used to give coumarin, but still you're not able to get the ideal INR, you know. We used to combine with aspirin, one of the antiplatelets, you know. I don't know what's the current status in that.
In the olden days when we used Star
Yeah.
Edwards, we used to give
Yeah.
only aspirin.
Yeah, that was Stanley John's biotic valve. You don't need, but that was a disaster after that we found, you know.
Yeah.
Okay. All right.
All right. Thank you.
Thank you. Very good, Karan. Thank you.
Good. So please write down all these things and then, you know, you must have it practice talking about this in a number of times.
Sure, sir.
Okay. Thank you, sir.
Thank you very much.